Well, considering all of the studies that have been done, and this is just a one summary slide, looking at every medicine up to the anti-TNF data for prevention of clinical recurrence and prevention of endoscopic recurrence, with placebo on top, followed by 5-ASA budesonide, the antibiotics, and azathioprine 6-MP. And if you focus on the green, the endoscopic recurrence, which we would consider the most rigorous outcome, you can see that generally the rates of endoscopic recurrence are fairly high. And although I'm not showing each of the comparisons and p-values, most of them were not better than placebo. When we consider all of the endoscopic recurrence rate, what do we find is that at best endoscopic recurrence rates, primarily with azathioprine 6-MP, and maybe combining with antibiotics as a very unique strategy that one group has recently published. But still at best, our endoscopic recurrence is about 45% at a year. What does this mean? It means that the patients that you have go to surgery, if we put them on these medicines, then in the year they're having this endoscopic recurrence, there's still a very high rate of surgery. So from the surgeons, we have 6 surgeons that do IBD at our center. They love this because they see these patients back and they cynically joke that it's just a matter of time until they see them again for their next surgery. And I think probably until recently they're correct. These are patients who would come back for multiple surgeries. We also have a small bowel transplant center. Starzl handpicked somebody to do small bowel transplants in Pittsburgh, so they've done over 100 Crohn's disease small bowel transplants, and these are people who have 10 inches of their small bowel left, and they're coming from all over the world, but this is the most aggressive course. But this is what, unfortunately, we see with patients who undergo surgery for Crohn's disease. So is there a better way to prevent post-op Crohn's? This is the study we published, and let me pause for a second. In no way would I recommend every patient go on anti-TNF after surgery. That is absolutely not the intention of what I'm about to present, nor do I think we have the data yet to suggest that that is the case. I will provide our data, but also possibly a strategy by which to choose and select certain patients who may be at higher risk. And obviously now with the PREVENT study, this post-op anti-TNF study, those are the data that we really need to make this decision. Nonetheless, we put together a small pilot study that was published in Gastroenterology in 2009, looking at starting anti-TNF in the form of infliximab immediately after surgery and seeing if we can prevent the recurrence. So this was randomized, 2-arm, double-blind, placebo-controlled study. We did a sample size calculation. This was really a proof of concept study. This was not intended to be a pivotal be-all end-all study, but what we did is we assumed that there would be an 80% endoscopic. So recurrence here is endoscopic. Clinical recurrence was secondary. 80% endoscopic recurrence if we put the patient on placebo, and we assumed an endoscopic recurrence of 20% in the infliximab group, and we came up a number of 24 patients needed to treat. So we took 24 patients who underwent an ileocecal resection, who the surgeon, when they left the operating room, could not detect any active Crohn's above the anastomosis or below the anastomosis. So for that split second, they were in a surgical remission. We took those patients, and within 4 weeks of surgery, and practically speaking, what did we do? The patient came back for their 2-week visit. We made sure there was no wound complication or infection. We had already enrolled them in the study so that they were ready to receive placebo or infliximab. Within basically about 20 days after surgery, most of the patients had their first infusion. So they got 0 to 6 weeks and then every 8-week infusions thereafter.
Were they all infliximab naive?
No, and I'll come to that in a minute. There were some that were not, but the bottom line, the ones that were not were all what I would consider should have gone to surgery a year ago, and infliximab was given as a last-ditch effort, meaning that the patients who had received infliximab all received it within 6 months of surgery. But when you look back, they were having obstructive and infectious complications for a year prior to that. So they were not all infliximab naive, but I wouldn't consider them primary failures because these are people probably who should have had surgery anyway. So our primary outcome, again, was the proportion of patients with an endoscopic recurrence 1 year after an ileal resection. Secondary outcomes, we did look at clinical recurrence and remission, histologic parameters, and then there were some other some other inflammatory markers we looked at as well. So just as a reminder, endoscopic remission, we used the Rutgers scoring system, was termed as 0 normal or less than 5 ulcers in the 1 group, and then endoscopic recurrence was 2, 3, or 4. So this was our primary outcome. So demographics, and this gets to this a little bit and answers your question also. The left-hand column is infliximab, the right is placebo. If you look down the different demographics for gender, age, duration of disease, location, phenotype, most of these patients were fistula. So not that we did this intentionally, but in a sense, these were the highest risk for recurrence patients postoperatively. There were 8 patients who had received prior infliximab. All of them within 6 months of surgery. Most of them had just received a dose or 2 within 2 months of surgery, and these were patients referred in. And I think the gastroenterologist with good intention was saying, can we avoid surgery? Let's give you infliximab. And the reality is, by the time we saw them, they really probably should have gone to surgery earlier. All of the patients had at least this one surgery, but there were 4 patients in each group that this was their 2nd or 3rd surgery. Interestingly, 11 of the patients came in on azathioprine 6-MP and had been on this treatment for greater than 6 months. I will say that even the patients that received placebo did not stop their concomitant immunomodulator or 5-ASA. This was a concern we had with a small study. Should we stop everything and just really use placebo? We elected to continue the 5-ASA and azathioprine 6-MP that they were on coming into the study. One interesting aspect is active smokers, and this is where a small study, you spend long nights awake sweating about the data. My biostatistician was the first to receive the data and called me up when the study was over, and he said, I have good news and bad news. And I'm thinking, okay, there's going to be something with the numbers. And he said, it has to do with smoking. And I thought, all right, well, if there are more active smokers than placebo, I wouldn't be standing here today presenting these data, because everybody would say that smoking was the factor by which you saw a high rate of placebo recurrence. He said the good news is it was flipped. You had more active smokers in the active treatment arm infliximab than you did in the placebo arm. So even though it wasn't statistically different, and this was obviously blinded, if anything, the smoking would have weighed against the active treatment. So what was the bottom line? And this is the bottom line take-home slide from our study. The red is placebo, the yellow is infliximab. And what we saw is that 85% of the patients who received placebo had an ileal score of 2, 3, or 4, whereas only one of the infliximab patients had a score of, actually had a score of 3. I will say that the one infliximab patient who did have a recurrence of Crohn's disease was infliximab naive. That was not a patient who had previously received infliximab. The question then also is, when you do these scores, and as you start to do the PREVENT study, some of it's subjective. So I would score it first, then I would video record it. Then we had 24 discs that were not assigned an indicator of who the patient was. Then I had a second observer score all 24. Then I came back at the end and I scored all 24 again in a random blinded way. If we disagreed on scores and it was one of us thought it was a 4, the other thought it was a 3, which you could argue that's probably not a big deal. We had 2 of those where we looked at the 3 and a 4 and said it's probably a 4, or no, it's probably a 3, but those were at the higher end.